All right, everybody, thank you for being here. So we're going to start the private practice and office-based lab panel. Just want to thank Satya Morar, our executive chair, as well as Naveed Zaman, my co-chair. We are very honored to be joined by Dr. Kavi Devulapalli. He will be our moderator for this session. He is an independent endovascular and image-guided surgeon at the Image Guided Solutions of Missouri. He went to medical school at Case Western Reserve University. He did his residency at the University of California, San Francisco, and completed his fellowship at the University of North Carolina. Some of his clinical interests include benign prostatic hyperplasia, uterine fibroids, venous disease, and critical limb ischemia. We are also honored to be joined by Dr. Baheti. She's a vascular and interventional radiologist at Sound Vascular and Vein in Washington. She completed all of her training at the University of Virginia. That includes medical school residency and fellowship. She has clinical focuses in peripheral arterial disease, venous thromboembolic disease, superficial venous disease, and women's health.
We're also will be joined by Dr. Christopher Pittman. He's a vascular and interventional radiologist and also the medical director and CEO of Vein 911 Vein Treatment Centers in Florida. He completed his training of medical school in University of South Florida, his residency in radiology at St. Louis University, and his fellowship at the University of California, San Diego. And his clinical focus is venous and lymphatic disorders. And last but certainly not least is our other panelist, Dr. John Lipman. He's also a vascular and interventional radiologist and founder and medical director of the Atlanta Fibroid Center in Georgia. For his training, he completed his medical school at the Georgetown University, his residency in radiology at Brigham and Women's, and his fellowship at Yale New Haven. And his interests involve uterine fibroid treatments, fallopian tubal infertility, and migraine headaches.
Great. Thank you all for that intro. We really appreciate being here today. I think this is my third year hosting. Hopefully we have a lot of new people in the audience. I see 40 people out there, which is excellent. And, probably some return people as well. So we thought I'd switch it up this year. We got some new panelists. I'm really excited to have some great folks with us today. I want to keep things informal. We have a few questions that we'll kind of run through with the panel. Dr. Pittman will be joining us at some point. I think he's actually in New Orleans for the Super Bowl, so he's probably a little occupied, but he'll pop in when he can. And when he does, we'll, try to give him the floor at that time. But really the session is for you all. This is your opportunity to ask us anything, really. We want to make ourselves accessible and really give you an idea of what life is like after training and being where over 80% of us actually practice, which is the private practice world. Before I jump into it, just a couple things. There's a lot of terminology that's thrown out there. There's this term private practice. There's this term OBL. I just want to make it pretty clear that these are two very different things. Private practice just basically refers to anything that's not employed. OBL is a site of service. Places where you can render service include an ambulatory surgical center and probably for most IRs, the hospital. We're a pretty unique panel. All of us are OBL or ASC in terms of where we provide our services. So we're mostly outpatient. That's where things tend to be trending for a lot of what we can do. So hopefully you get to hear some great stories today. I just want to take a brief step back and kind of start with our panelists and tell us a little bit more about yourself and what got you into IR and your career progression and where you are today. Why don't we start with Allie? I'm sure you guys all have heard Allie's voice. She's on the Back Table podcast, does an excellent job, but it's very cool to have her here today in this context. So take it away.
Kavi, thanks for having me on this panel. This is super cool. Okay, so yeah, I'm a very informal person, so it's going to be, I want everyone to be able to feel like they can ask questions. Very forward about kind of my career and what's been going on. What got me into IR is like one single person, Dr. John Engel at the University of Virginia. He is my mentor. He is like the greatest IR. He is like somebody I met as a medical student and has shaped my career immensely. I know Dr. V also thinks very highly of him, and we bonded over that. My career, John Fritz Engel has taught me a great deal about aortas. Yes, he has taught everybody a great deal about aortas. My initial experience as a IR doctor. I went into private practice in Wisconsin. I was just there for a year while my husband was doing a fellowship. But that job was amazing. I was doing EVARs. I was doing tons of legs. I just had a really great clinical practice. And then COVID hit. We moved out to Washington State, and I joined like a more traditional IR DR group that ended up being a little bit too much DR for me, basically. And I didn't feel like I was getting to do the cases I wanted to do. So I left. I became an independent contractor, started doing some locums, and then I really hooked up with an interventional nephrologist in my area who has an OBL ASC. And I thought that I could build a really great IR service line there in his outpatient space. And that's basically what I've been doing for the past 2 years. And it's been there's been challenges, but it's been so much fun. And I think it's a great space that trainees don't know about. I didn't know what an OBL or an ASC was when I was a trainee. I thought you just like left and worked for private practice or work in academics, but there's all these different ways to shape a career that we'll get into today.
Excellent. Thanks so much. That's wonderful. Great to have you here and to hear that background. In the comments, we're talking about the whole IR/DR thing, and it's funny because I think all of us on this panel were part of a radiology group at some point. And I'd love to hear from John, your story and how you got here.
Thanks. It's great to be on this panel, really. I'm like the old guy in the club. I've been around a long time, and I've practiced in pretty much every possible combination you can think of, except what you did in locums IR. I have not done that, but I started briefly in academics, and then I moved to a traditional private practice radiology group that didn't believe in a clinic. And I was used to having a clinic as a fellow, even as a resident. And that was kind of the deal breaker, that you had mentioned that your IR/DR is really more DR than IR. And that just wasn't going to be cutting it. I needed a clinic, and I insisted on it. But the problem was, when I finally was able to convince my DR colleagues, they would leave me several hours of work while I was in clinic all afternoon, and I came back to this huge pile at 5:30, and eventually I said, I got to strike out on my own. We're talking 2004. To me, there was only academics or privates, and I decided I'm just going to do this myself. I talked to referring physicians and said, if I do this by myself, would you still refer? And they said, yeah, we're not tied to the hospital. We wanted you to take care of our patients. And that's really important. The hospital doesn't allow physicians to market their brand. It's always the hospital's brand. And so it's really important to establish who you are and what you like to do. And fortunately, I was very lucky to continue doing what I love doing. And that was first as an independent contractor doing interventional. But then it became kind of clear that you really need access to the technical income if you're going to survive these days. And so we did a joint venture with a hospital on IR, 50-50 joint venture, which was it was excellent. But the hospital was itself a joint venture, and the two partners didn't really get along very well. And the hospital eventually closed, and we knew at that point we were just going to build our own center. And so I am the founder and medical director of the Atlanta Fibroid Center. And we are celebrating our 20th anniversary this year, 20 years as in an OBL. And it's just been phenomenal. It literally saved my life. No question about it. There is so much physician burnout, even physician suicide. I can talk a long time about how this is kind of a trap with educational debt and then servitude, and then but getting out into an OBL where you control the environment, control the brand, it just, all the burnout goes away. I mean, it really is a joy coming to work. I hope I can do this for a long, long time, because I really, truly, it's not cliche. I love going to work every day because I'm doing what I love and doing what I'm good at, and I don't do anything else. And it's phenomenal.
That's awesome. And you know, to
Oh, and one
everybody
other
out there.
thing, sorry. One other thing that you had mentioned that was really important, I think it's really key, is mentorship. It is so important. Mine happened to be Barry Katzen. When I was a second-year medical student at Georgetown, I was fortunate enough, he had never had a medical student before, but I knew of Barry, like he was doing these phenomenal things. I was reading about him in the newspaper. And so I asked him if I could do an elective time with him. And once I did that, it was like, wow, this is incredible. He's an incredible human being. And so I, just like Fritz for you, it was Barry Katzen for me.
Well, that's wonderful. I was able to see what your work is like real time when I came to visit, John. And for everybody out here, it truly is wonderful. When you have something that you love to do and you just show up every day and you do it and you have the ability to build it, it's really powerful. And I think that's something that draws us all to this space. I think all three of us here on this panel today feel that way. When Chris comes here, I'm pretty sure he would echo similar thoughts. You know, lots of interesting talk on the chat. You all mentioned, you know, being in an IR/DR group, some of the challenges there. And, you know, I think as a field in transition, a field in flux, I think what you see with WCVIS is really a progressive attitude towards IR. I think we're very clinically focused. That's, you know, what we want to do. I think a lot of us are surgically minded. I certainly am. I think everybody on this panel is. And, you know, one of the challenges really in an IR/DR setting is it's not really personal. A lot of it's the economics. I think John mentioned some of this, and then, you know, Ali, you did as well. We were all in IR/DR groups. And I think one of the pitfalls a lot of folks coming out of training have is they don't realize what is or isn't possible in an IR/DR setting. And it has nothing to do with the number of cool, quote unquote, cool cases you can do, but it's really your ability to care for patients over time. That's the biggest thing. And that all comes down to having a clinic. And the fundamental economics in most IR/DR settings is that makes it very hard to make that your primary focus. Not to say you can't have it, but if you do, it may not be the primary focus. And one of the discussions with sites of service is an OBL ASC can provide you that, because you cannot generate the cases and the revenue from those cases to support a business unless you did nothing but take good care of patients. So that's very, very critical. You know, I just want to give folks on this webinar an idea of what your lives are like, your day-to-day. What does Monday through Friday look like? Are you doing any kind of DR? Are you taking any call? What are you? I love it, John.
Zero.
What does that look like? So, Ali, why don't you tell everybody what life looks like?
Okay, full disclosure, I'm like a full-on crazy person. So I would not recommend this schedule to other people, but like I'll tell you what I'm doing this week. I on Mondays and Tuesdays, I read diagnostic radiology from home. I read for a group in Louisiana, and I read from like 8 a.m. to 3 p.m., which is their 5 p.m. What that allows me to do is drop my kids off at school, have a couple hours in the afternoon, and then pick them up afterwards. So those are and then also like do all the admin work for my OBL ASC those days, right? Wednesday and Thursday, I consider my operative days, right? I'm not a surgeon. This is a point of contention in my household. I'm not a surgeon. My husband's a surgeon, but those are like my operating days. So I go in to my lab. First case starts at 7:30. At this point, I try to do like 3 advanced cases a day. So think like this week on Wednesday, I have like, you know, a UFI and then a a UFI and then a central vein stent, and then I have a kypho in the afternoon. I run my lab either as a different site of service based on the day, and I usually do one OBL day and one ASC day. And I think that might be a little bit too advanced for this session, but basically different procedures reimburse differently in different sites of service. So I want to kind of optimize my reimbursement. And so I place patients in the lab on a certain day, depending on, you know, how much their insurance company is going to pay me in that side of service. And then Thursday I'll run as an ASC day, and I think I have some PAD cases there that day. And then Thursday night I'm flying to Spokane because I help cover a contract in Spokane. And I became really good friends with the IRs there, and they are Q2 call, and it's just like an insane hospital. So they would totally burn out. So I cover in Spokane from Friday through Sunday. So last weekend I did an emergent tips on a acute GI bleed. You know, like I still love that stuff because I'm fairly early in my career and I didn't want to lose all those fancy IR skills that I learned. But yeah, it's kind of a insane schedule, but also self-made insane. I will say, like, my diagnostic days are definitely my easiest, right? From a time perspective and like a turn your brain off perspective a little bit. Um, Financially, my diagnostic days are actually like oftentimes my most lucrative. So I'll say, like, if you're going into IR because you think you're going to make a lot of money, like, I don't think that's a great way to be. I think just with the way the market's going, if you're doing it to make a ton of money, that might not be the best scenario. But like this is a way that I'm able to engineer like multiple jobs together to fit what I need to fulfill me clinically. Um, and it's awesome. So that's my week.
That's great. John, how about your week?
My week is a lot easier. Um, I do absolutely no DR. I have no call, no nights or weekends, but I do a lot of stuff outside of the lab. Like every Monday through Friday in the mornings, we start at 6:30. I'll do anywhere from 2 or 3 UFEs to as many as 6 UFEs Monday through Friday. And then I start clinic every afternoon at 1 o'clock and see patients, new patients and follow-ups every afternoon. And that's my life. And it's very simple. It's all IR, no DR, no traveling. We have 5,400 square feet. It's connected. I have a clinical side and an admin side. And so I do my procedures in the morning and literally walk to the other side of my office. It's connected and start seeing patients in clinic. And it's incredibly joyful. All I do is fibroids and adenomyosis now. That's all I do. And I love doing it, good at it. I like caring for these patients. And it has really brought just tremendous joy. It's made me a better physician, a better husband, a better friend, a better dad. Because, when you're doing what you love to do and what you're good at, it just brings so much joy. And the patients are so grateful for the experience. I mean, you saw, I think, Kavi, patients come to our center. It's very convenient. It's easy. You walk in the front door. The parking is right out front. And all the staff is happy to be there because I hired them all. And communication is 80% nonverbal. So when your staff really loves coming to work like you do, this positivity just radiates to the patients and they pick up on it, and it goes back to the referring physician. And we have patients say, I haven't had this experience since I was at the Four Seasons or the Ritz-Carlton. This is amazing. I've never experienced this in healthcare. And I say, there's an expression, and I talk about this. I talked about it at Southeastern Angio, called ikigai. It's a Japanese term for your reason for being. It's this Venn diagram that's the intersection of 4 things. It's what you love to do, what you're good at, what the world needs, and what you can get paid for. And right at the center of that is ikigai, and that's where I live. I live in joy. It's truly great. And shameless plug, if anybody else wants to join our joy, we're looking for additional people that want to come work with us. And if they're at SIR, they live near Nashville, definitely hit me up. We're going to be rooftop on the top of the Joseph Hotel during SIR, and love to talk to any prospective people that want to join the OBL life.
That's fantastic. John, I do need to ask you, how many years were you in an IRDR practice before you went full outpatient?
Too long, but 14.
14.
Yeah, I mean, believe me, the last like 4 or 5, I mean, we're doing all this, trying to do clinic, trying to get home, every night at 9 o'clock because I had like 3 or 4 hours of extra work to do, and thinking that was the only thing. Either if I didn't do this, what else was I going to do? And when I finally had enough, I just said, I'm leaving. And they're like, well, where are you going? I'm like, I don't know. I'm just leaving you guys. I'm staying here and we're going to figure it out. Now there's all sorts of support. I mean, there's OEIS, which is great. You can learn a lot of business stuff because I never knew any business stuff. No one ever. In fact, I interview medical students at Morehouse for Morehouse School of Medicine. And I've been working with them trying to get some basic business concepts, business 101, simple stuff into the curriculum. You know, we need to know some of this basic business stuff so that we can, you know, do that. I just learned on the fly. I mean, it was, you make mistakes and you just kind of, but now there's a lot more education. There's a lot more examples of people doing this, and there's meetings and support. So it's a lot easier entry now.
That's a good point. And, definitely plug into OEIS. It's taught me a lot working with people like John, Bill Julian, Jerry Nedjvietsky, so many others in IR in our field who've done this. I'll take a minute and talk about my week, because I think all of our weeks might look a little different. I probably trend a little closer to Allie now, but I'm trying to aspire to be more like John.
Yeah, John is like life goals. Yeah, so we will get there eventually, John. We're just not there yet.
Exactly. So, I opened an outpatient practice. I was previously in an OBL a few years ago in North Carolina, and life brought me to Missouri, where I opened an outpatient practice in November. And basically, the way my practice works is I'm open 4 days a week, Monday through Thursday. Heavy clinic. I'm probably seeing 25, 30 patients a week easily, if not more. And basically, kind of starting slow and building up the procedures, because there's a lot of capital expenses that go into building clinic infrastructure and eventually an outpatient lab. And I think that's something everybody needs to know about. Yeah. So you do need to have some time in the game to build up some capital and to save some money in order to do this. And even if you do it on the cheap, like I am, it can cost you easily $15,000 or more a month in recurring expenses to have simply a medical assistant and a sonographer and, basic equipment to do something as simple as vein procedures. Then all of a sudden you introduce a C-arm and you start doing outpatient, angio cases or kyphoplasties, whatnot. Your expenses go up from there. You have to hire techs, you have to hire nurses. It's very possible that, before you blink and know it, you're running over 6 figures in monthly expenses, which means that you have to be clinically busy. You can't be clinically busy unless you have a name, reputation, you have excellent outcomes, and you actually achieve referrals. So one of the things that was, mentioned in the chat was, how do you guys get referrals? I think we all have our unique ways of doing it. I tend to be in a smaller environment, a town of 150,000 people. There's no outpatient IR here. I'm the only game in town. So I think in some sense, maybe that's a little easier. I'm limited by the patient base though, but it takes time. I think, John would tell you, he's had a lot of time in Atlanta, and there's a lot of work that went up to do that. Allie will tell you she's worked really hard in Tacoma to do what she's done. But, in a nutshell, it's not easy. I think it can be very beneficial, very, great. You get out of moral injury, the burnout issues that John talked about. I totally believe that. I certainly make less money than I did doing locums and than I did working in an IRDR group. I'll probably get to a point where I'll make as much, if not more, but it takes time. It's hard. I think to Allie's point, if you're young in the game and doing this, you do have to supplement your time doing other things in order to keep the wheels turning. Either that, or you have to take out a huge loan or dip into capital, which requires years to gain and acquire, especially if you're coming out of training with educational debt. So for me, my evenings and weekends does look like doing some teleradiology or IR locums. I'm an adjunct professor over at the University of Missouri. I take weekend call 1 weekend a month. I think it's busy. I find myself working 70, 80 hours a week. I will phase that out and get to a normal 40 to 50, be more like John here in a couple of years. But I think there's this notion out there that people use the phrase, just go OBL. And I don't think it's that.
Yeah.
I don't think it's that easy. I think it's doable. And to John's point, there is support now and you can do it. And if you're at the point where the traditional, pathway of practicing IR does cause that moral injury, like it probably did for all of us here, I think you got to do it. But, just being realistic about what that looks like. So there you got it. You got, 3 people here with, different paths, different stages. I think that's great. We talked about this a little bit, but I want to make sure that we do address it. I want to talk more about clinical care referrals and kind of challenges that you guys may or may not have had in terms of acquiring referrals for your practice. So Allie, if you can let us know when you see patients in clinic, how often you're seeing patients in clinic, and where are these patients coming from?
Okay, so like currently I do cases and my last case usually ends at like 2:30. So then 2:30 to 5, I'll see a clinic patient every half hour. And it's like my clinic is just me and an MA, right? And it's just attached to the just like John's, it's attached to the ASC. Um and how do I get referrals? Well, I work in a place that has a lot of hospital consolidation. So most of the private practices have been bought up by the hospitals. So there's not that many independent providers. But that's really my main target is so I go around and I do marketing events at all of the independent primary care doctors, a lot of the ortho groups, and things like that. I found a really great non-surgical GYN group that sends me tons of UFEs, things like that, and just targeting who is going to be a good refer. But hospital systems make it really hard because you can just go into Epic and click a button that's like refer to IR or refer out to refer to vascular surgery, and to refer to me, they have to print out a form and fax it in. And that's like a barrier that's like too much for a lot of places. So I don't think I definitely right now am not busy enough to have a practice that runs 4 days a week. And that's why I do all this other stuff. John was in his community for a long time, built up a lot of relationship with referrers. I was practicing in Tacoma for about 3 years beforehand. And so I've taken those referrers with me that like me. But even then, like once you leave the hospital, people forget about you, right? They forget that you exist. They'll try to refer to you as much as they can, but then they just fall into the trap of what's easiest to do. And so I'm like facing growing pains, definitely doing that. And then a lot of patients I do get by direct to patient marketing. So a lot of the GAEs and the prostates that I've gotten so far are from direct to patient marketing, and using digital marketing services.
Excellent. You certainly have built up a lot in a short period of time. So I think it's impressive. I think, your trajectory is awesome. So I'm certainly learning from that. I think it's great that people got to hear that perspective. John, curious how you built the machine that is Atlanta Fibroid.
Well, I mean, yeah, it takes a lot of time and a lot of effort. As I say, I don't have call per se, I don't take call, I don't do nights or weekends, but I'm out in the community instead, and I'm working for me, I'm working for our brand. We're very intentional. We know who our market is, we know who our audience is. It's young African American women, somewhere between 25 and 55. And so we're out in the community a lot. I do a lot of events. I do a lot of speaking events. I do a lot of educational events because, again, a lot of people, even after over 25 years of doing this, still most people aren't given this option. Most people aren't aware of this. It's a real tragedy. In fact, I don't know how those that don't mention it in the OBGYN world, I don't know how they sleep at night. It's truly one of the biggest medical breakthroughs for women. But so we educate a lot, and we're in social media stuff and on all those channels. That's important, and getting into doctors' offices as best you can. That's important. Now you got to do everything really, and so decide who you're marketing to, know that audience, and try to show up in front of them and be the go-to person. I mean, I think we're the go-to in Atlanta for fibroids. I think, having built that over many years, there's lots of competition here. There's lots of other people in town that can do a UFE. And it's not a difficult procedure, as you know, but it's what we do. And that's how we separate ourselves. Yes, you can get it done at Emory, but this is what I do each and every day of the week. This is what I'm doing. And it makes a difference like anything else. You want to go to the person that's done over 10,000 UFEs versus, someone that maybe has done only 50 or 100. And, we'll see people from all over. And pre-COVID, we saw people coming from other countries because you can fly nonstop from Atlanta just about anywhere in the world. Not as much now, but still, you got to build your brand and realize who your audience is.
Excellent. I think it also goes to the point earlier that, yes, you may not be taking night call, but that's a lot of work, and you do it because you love it and you believe in it. And it probably doesn't even feel like work to you.
No.
And And that's how I feel too about a lot of the outreach events that I do here in Central Missouri. I'm sure Allie feels the same way in Tacoma. You know, when we're going out, we're meeting with the community, we're taking people out for dinner, we're doing all these, you know, community engagements. That's time. That's time away from your families. You know, that's, you know, very different from a diagnostic lifestyle. You turn that workstation off at 5 p.m., you're done. This never ends. Even though there may not be call per se, you have to live it. And if you don't live it in that fashion where you truly internalize your love and appreciation for what you do and what you believe in, it won't fly. So I think it's really good to hear that.
Yeah, and I know I get people asking me, you know, how do you do this? Well, the first thing I'd say is get the absolute best training that you can get. And then decide, once you've gotten the best training, decide what kind of procedures you like to do and what you're good at. And then start heading in that direction. But it all starts with your training, getting the very best. And then you can do these things. If you're a really well-trained IR person, you know, you can get the other entrepreneurial stuff and the business stuff, but it all starts with being, because you're on an island, you're not in the hospital. And so get the very best training you can. And I think it all starts there.
Oh, okay. I want to say one thing. I think you said something really important. I think it's really important to work in a hospital for a little bit as a fresh attending and not go straight to outpatient land. Okay. You're going to mess up. You're going to mess up your first few years out. You're going to get yourself into situations that you want to know how to bail yourself out of. You want to do that stuff like in a protected hospital environment. In the best case scenario with people who can also help you there. When you're on an OBL or an ASC, you are on an island. Like you are the only doctor there. If anything happens, you can't call for help really. All you can really do is transfer a patient via transfer agreement. So yeah, you gotta be really good at what you do. And you gotta, I guess the other push I would say is like in the hospital, you get to use whatever supplies you want. So you figure out what you like, what atherectomy products you like, what embospheres or what embolic do you like, you know? And it's not the same when you're in an outpatient setting.
Excellent advice. You know, I echo that. You know, I know training has also changed, so, you know, but I still do think it's good to have some kind of hospital experience beforehand. We got Dr. Chris Pittman with us, live from New Orleans.
Kavi, I totally agree, and I apologize. This is so important, and I really appreciate the invite. Hopefully I can help some people. Look, you guys need to get more excited about IR, okay? There's a lot of things you can do, honestly. Look, I'm a policy wonk, and no one's more excited about the future of healthcare than me generally and a pack of doctors. There's too much thumb sucking going on, and I hope you can hear me okay. But yes, I'm in the middle of New Orleans. In any case, you definitely should start in a hospital system if you're just getting out of training. Okay, go do your time. Go get righteously indignant with the bull crap going on there. Learn some things. Decide. You know, it takes a good 5 years to really mature as a physician after you come out of training. So do your time, but then don't hesitate to go out on your own. But don't do it alone. And I'm not here to promote myself or the things that I'm doing, but we help practices, okay, to stand up and stay out of trouble and survive and thrive. And so you don't do it on your own. You don't win in business on your own. You don't win in politics on your own. There are people you can rely on. You're not all by yourself, but you have to have the courage to step out. It's a trite saying, nothing risk, nothing gain, but by God, it's a calculated risk, right? In business, you take calculated risks. And if you have people who've been there, done that, like Dr. Lipman, congratulations to him. There's not enough people like him going into narrower areas. In IR, I'm going to try to hit as many topics as I can until Kavi turns me off. You've got to pick one or two things. Jack of all trades, master of none. I get it. We're trained to do all sorts of stuff. I did all that stuff. There's not an intervention you can mention that I have not done in my career. However, you relegate yourself to a commodity. If you want to be among the best in the world at something, because we have a worldwide economy, okay, it's not a trite saying, it's true. People will find you. Then narrow down into one or two areas: musculoskeletal, fibroids, venous and lymphatic medicine, oncology. Look at Wayne Yakes. Anybody who doesn't know Wayne Yakes and what that guy was able to create in Colorado Springs decades ago. This guy's a pioneer. Lipman's a pioneer. He does nothing but AVMs. If you have an AVM, by God, I'm going to Wayne Yakes. So you don't want to be a commodity. There is help out there. You got to fail your way to success, but you don't need to lose your butt doing it. I'm coming in for a landing. I'm on the 10-yard line here, Kavi. Look, if you fail, there's some hospital that's gonna pay you $600,000 or more a year anyway. You only got one, it's not a dress rehearsal. Don't live a life of quiet desperation. Go help a bunch of people. There's nothing like being a successful entrepreneur. I would no sooner go back to a hospital system. I would live in a tent. Of course, that will never happen. There is help out there. Talk to John. Anyone who's successful out there doing IR by themselves is happy to tell you how they got there. I'll quit. Thanks, Kavi.
Thanks, Chris. Really appreciate you taking a few minutes to, impart that wisdom on the group. Certainly the same wisdom you imparted on me the last few years. I had the opportunity to work with Chris in his vein 911 practices for a little bit, which was tremendous. We had a great question while we still got Chris on the line. John and Allie, like you to chime in as well. There was a really interesting question about, healthcare economics and some of the issues that we're having today with declining physician reimbursements, increasing technical reimbursements for facilities, and what that might look like for the future of private practice, in particular outpatient interventional radiology. I think it's a really timely question. I think it's one that everybody here grapples with on a daily basis. So, I'll turn it over to Chris real quickly while we have him. Chris, what do you say to young folks out there who are committed to medicine and are worried about these things?
Here's what I tell them and old guys like me and John Lipman. They've been cutting our salary every year for 40 years. Where you guys been? Here's the point. It's not about how much you're paid. I preach this to our network all the time. There's a denominator. What can you do for the money that you do in an efficient manner? The future of healthcare is volume, efficiency, outcomes. Hopefully not in that order. Volume, efficiency, outcomes. You want to see a well-oiled machine? Go visit Lipman. I'm sure it's well-oiled. I bet he doesn't care how low it goes. Payment always goes down. I don't care where payment goes in vein care. We will be here. We will have models to succeed. It's a much longer answer that none of us want to hear me say. You want to invite me back for an hour or something, we can delve into it. But in business and medicine, things change all the time. And when you're a young physician, because I've hired many of them, you think it's going to be like this 30 years from now. It's not. Things change every 6 months, and you have to be willing to change. We have a new administration. Who the hell knows what's coming? So you don't want to project out too far and make the wrong decision about what you want to do with your career. I used to lecture on health IT, and medical students would say, oh, geez, should I leave medicine? I'm like, no. No, it's going to impact healthcare, but it will never replace physicians and the connection and empathy of a physician and that patient. So it's a much longer answer. Don't worry about that. Worry about managing yourself and your staff better, and then all the problems will go away. You manage your costs to the best that you can. We have limited ability to manage what we're paid, but it depends on how long it takes you to do it. I bet Lipman can do a fibroid embo in 5 minutes. So I'll end with this. 20 years ago, I asked my new fellows what was the most lucrative thing we did in the practice. And, you get aortic stent graft and covered stent and all this garbage, frankly. I call them chest pounding procedures. They're fun, they're sexy, they're exciting, but they're not going to pay the bills. Okay. So the actual fact is a PICC line was the most lucrative thing we did. It took me 90 seconds to do it. We cleared $160. There was no more lucrative procedure in interventional medicine than a PICC line, but it was beneath every other IR. You got to think differently. And now the hospitals and their nurse teams are more than happy to bill for all of that stuff. It might not be sexy, but we could have subsidized a lot of stuff just keeping PICC lines or teaching a mid-level to do it, but keeping control of that revenue stream. It's not about what you're paid. There's only $160, but it took 90 seconds to do it. I hope that makes sense. Thank you.
No, that's a great answer. John, what do you think about this? I mean, you've kind of been through an interesting era where in the initial part of your career, there wasn't even office-based reimbursement for embolization. Right. And you've kind of seen it unfold. What are your thoughts?
Well, I say we never worried about the money. I mean, we just do the best you can do. There's certain things you control and certain things you don't. But what you can control is, how you care for people and just doing the very best you can do and be, and the money will follow. I mean, to say you can't control these other things about declining reimbursements every year. Yeah, that's true. And who knows where this is going to go. But, I'm in a great space. I love doing what I do. I think it's going to continue. And now with more and more people in the space, I know we're going to win the day. I mean, back in the day, it's like politics. I mean, there were, Democrats and Republicans, but now there's this third party. It was always either academics or privates, but this third party wave, I think, and more people are getting into that space, and more patients love that space. It's going to demand attention, and it's saved my life, and I think it's here to stay. We've been hearing doom and gloom about IR forever and ever. You just got to turn out the noise and just tune it out. Just, do your very best. You're trained, to be an IR, and just do the best you can do. And don't worry about these other things, and just keep going forward, because I think the future is very bright for IR, particularly in the OBL space.
It's very, very inspiring, and I think it's a good message. Allie, what are your thoughts? You're like me, you're a little earlier on. What do you think about all this?
Couple things. Okay, you guys are all way smarter than I was already. So when you come out, you're going to be very well trained, and a lot of people are going to want to take advantage of you. People are going to want to hire you in an employed position in their OBL without any equity. They're basically they want you to be like the outpatient version of Line Monkey, for example. So whatever you're doing, just like, you have to understand that ownership is like the key to your future. It might sound good that you're making a really great salary 1 year out, your first year out. But then you think like, okay, 10 years down the line, am I going to be doing the same thing? Am I going to be doing 3 prostates a day and then being done by 2 and then going to the gym and then not making any more money? If anything, making less money because the physician fee schedule is dropping every year? No. The difference, everybody that's on this panel that Kavi chose for a reason understands that entrepreneurial mindset. And oh man, I really want to say something, but it's inappropriate.
You should
so I'm
say
just
it.
gonna not
say
look.
it.
You should say it. Blame me.
Everybody is somebody's bitch, right? Always.
Sure.
So who are you going to work for? Who are you going to be making money for? Are you going to be making money for yourself and your career and building the career and the practice you want? Are you going to be making it for the hospital? Are you going to be making it for some DR group? Are you going to be making it for some private equity group that owns a bunch of outpatient labs? You decide. You decide where you want to go here. There's lots of consultants in the OBL space, and Mary Constantino has a very wise saying. She says a consultant is somebody who can take your watch and show you the time. There are a lot of people in this space who don't know who maybe have a niche interest or a niche specialty, can help you with one specific part of it, and they want to charge you hourly, but you're the one paying the bills. And a lot of that information is honestly like available for free and available by talking to other people like us who will gladly guide you through it without charging you an arm and a leg. So the generation before me, Chris Pittman, John Lipman, y'all, you guys are like the entrepreneurs. You're like Gen 1. Me and Kavi are like Gen 2, and you guys are going to be Gen 3. That's all.
I think that's very well stated. And you're right. At the end of the day, you got to answer to somebody. And I think, a couple things. I think one inspiring thought, I think John, Chris, Ali, you guys all, mentioned this or touched on this in one sense. Think about the most common conditions that are out there that we have a treatment for with really good data, right? Think about what John does with fibroids. Think about what Chris does with veins. He opened my eyes to venous disease. It's the most common thing out there. You can't turn your head without coming across venous disease. Why are we not more involved as IRs, right? Think about men's health issues, benign prostatic hyperplasia. Think about women's health issues, right? Chronic pain, musculoskeletal, vertebral compression fractures, osteoporosis management. When you take all these entities together and combine them up in the US, you're talking at least 50 million people, if not more, probably 1 billion people globally. Yet what do we spend most of our time doing in IR? Not that. So I encourage everybody here to think about how they can get involved in these common outpatient conditions. Nothing's perfect. There was a question earlier that I want to make sure is addressed. There's a question about case selection in the outpatient setting. I think, there's some patients that you just can't treat outpatient. When you're thinking about moderate sedation, especially in an office where you may not have anesthesia, some do, but most don't. You can't do everything. You got to be very mindful of cardiovascular status. You got to think about non-revascularized coronary disease, aortic stenosis, pulmonary hypertension, low EF. Those are the 4 things that you have to keep in mind, and you got to be safe. And sometimes you just can't do it. And if you're like me and you're kind of riding the silver tsunami of old folks who need treatment, or things like kyphoplasties for compression fractures or PAD or BPH, not everyone can be done in the office. So there's that limitation, but I'd say 95% can. So still a lot of things there. If you're dealing with superficial venous disease, you could pretty much treat everyone in an office. And there's probably a lot of people not being treated. So it is important to be cognizant of that. Ideally, you'd have access to multiple sites of service, but that's not true. That segues into a final question that was brought up that I want to make sure is addressed. I think the question was something to the effect of what's it going to look like in terms of lobbying for our professional societies to make sure independent IRs, as we are here on this panel, are able to kind of flourish in their chosen practices. I think things are slow. I think they're frustrating. And when you're like me and you're in like year 7, you only seen the 7 years, but then you take a step back and you look at somebody like Chris or John who've been doing this for decades and kind of seeing what they've experienced. When you think decades, things look very different probably for them now than they did 20 or 30 years ago. And I suspect that'll be the case for folks like Ali and myself and for you guys coming up behind us. Whereas I do think there honestly is a natural divergence between IR and DR. And I think the focus really is on those of you who want to be joining us in this to help push for that, but to also promote appropriate pathways for us to practice. And I don't think that's possible unless we do tackle those 50 million patients that are probably being ignored by most of us out there. So, that's something that's tough because it's not something you get a lot of exposure to. I'd probably think that this hour has, afforded you more exposure to this world than probably any other programming you've had to this point, I would think. But I encourage you guys to get out there and see what's possible. And, getting to everyone else's points here, which are very critical. Things are going to change and you have to adapt. Any other thoughts for anyone here?
Yeah, if I can give one more thought and then I'm gonna get on with the day. If you insist on being a commodity and doing everything in IR, you will never succeed as an entrepreneur. Chick-fil-A only has chicken, don't serve hot dogs there. Become among the best in the world at something, okay? And you don't need, the payers don't matter, referrals don't matter, hospitals don't matter. So be like a Dr. Beal, become among the best in the world at musculoskeletal. or oncology or veins, and nothing else matters. But we have to get out of this mindset. We're not defined by an organ system, which is a problem and a longer conversation. We're defined by a modality, which is terrible. So find whatever your niche is, become among the best in the world at it, and you will succeed. Now, in the meantime, you can read some x-rays and go moonlight and all that, like I did when I made the transition. But ultimately, the patients will find you. I don't need another referral in my life and I'll be fine. That's like completely opposite from being a bottom feeder as a radiologist, right? It's such an amazing feeling. And same with Dr. Lipman. People are going to find him because he's among the best in the world. That's the toughest question you all need to answer is, am I willing to stop doing the other stuff and focus on one or two things? Thanks so much, Kavi, for inviting me. And I wish the best of luck to all of you. You can give me my phone or email. Happy to talk to anybody. Thank you.
Thanks so much, Chris.
I
We
wish I
appreciate
was
it.
there with you, Chris. I was really hopeful so I could wear this. Except Patrick Mahomes had some other ideas. I wish I was there with you.
Me too, actually. I was pulling for them. Anyways, thank you, everybody. Have a great day.
Great. Well, I guess we'll, go ahead and end it here. Really appreciate everybody coming out and hearing what we had to say, and appreciate the opportunity to help out today.
Go Chiefs.
Chiefs. Shame on you. They broke my heart.
I know, man. I'm a Redskins fan. That broke my heart. Do you know how close we got?
Yeah,
Painful.
I know. Gosh, it's a tough one. Well, I really appreciate it, Kavi. It was great. I said,
Yeah, that was a great session.
love talking about OBLs. I say it's our way out. I mean, it's how we rescue medicine. It really is. I mean, that's how we take it back. We kind of lost our way a bit with all this employment by hospitals and insurance companies, but this is our way out. This is how we rescue it.
Absolutely. I'm glad you guys were able to join today and share your stories. I think the comment about expertise is just critical, and it may be a little puzzling, folks are still listening, because one of the selling points for VIR is the ability to do anything head to toe, minimally invasively. But the truth is, when you get out there and you're focused, you really do need to probably focus on maybe one or two things and get really good at it. I've kind of noticed that myself. And, it's an interesting thing, because you get attracted to a specialty thinking you're going to do everything, but I don't think anybody truly does everything at a high level. Would you guys agree with that?
Yeah, I'd agree with that. Yeah.
So I'm actually thinking, I'm in the process of hiring a vascular surgeon to come do the PAD at my place, because I love it. Like, PAD is great, but I feel like I am building a lot more traction for the embo procedures and for kyphoplasties. And like, I don't feel like I'm doing a good enough job doing longitudinal care for my PAD patients. So yeah, so I totally agree. But I think, like, early on, if you want to be diverse, that's fine until something sticks, But yeah, like, eventually, yes, you do have to nail it down to what you really just want to be doing.
Right, exactly. And I guess if anything, maybe a selling point for IR would be that maybe IR affords you time to figure out what that one thing or two things will be. Unlike going to a surgical subspecialty where you're pretty much going to make that your focus,
And there's no shame in that. I mean, you telling people, like, you only do fibroids, that's it? Like, I like to do everything. Well, yeah, that's great. And, we used to do everything, but I think you're right. You got to find, that area that you really want to focus on, because I think Chris is right that I don't think you can be truly successful doing everything. You can do that for a while, but at some point, I think you want to establish yourself as a go-to person in something.
Exactly.
Oh, and
Interesting question
sorry.
here. Oh, sorry. Go ahead, Allie.
Yeah. Last thing is just like if I was in your shoes, guys, I would like, and I was deciding, am I going to open an OBL or an OBL ASC? I would definitely lean towards the hybrid model just because of the way reimbursements are going. I think that's really going to flush out within the next 5 years. Like somebody who's a thought leader in the OBL space told me that he thinks that 40% of OBLs around the country are going to close down in the next 5 years just because of reimbursements.
Yeah, there's going to be changes. Things will adapt, and and I think it's interesting to note that prior to 2014, there wasn't even embolization codes for the office. Think about it; it's only been 10 years.
Yeah.
Things change quickly. Definitely, it's good advice, though. You need to, be able to work across sites of service if possible.
Mm-hmm. Cool.
Let's see. If you guys have time for a couple other questions, we got some coming through the chat here. Dr. Vatican Cherry says, how do you get the most out of your medical student in residency training in order to succeed as a clinical VIR? Allie, what do you think about that?
Most out of your medical training? Like if I was a med student right now, man, all the things that have been stressed so far in this conference, right? Like, so do as much clinic as possible because you're going to be the person seeing the patient and making the clinical decisions. Get really technically good. Just pick the brains of your mentors. Watch how they deal with complications. Luke Wilkins has a saying: "There's nothing better than a complication during fellow year because you get to see how your attending manages it, right?" Um, and then see if you have the ability to choose what program you go to. See if you can go to somewhere that does a wide variety of cases. Aortas all the way to outpatient stuff. A lot of the academic programs now have their own OBLs that students and staff can rotate through. And those are usually pretty well run and great places to understand some of the business side.
Great. John, would you do anything differently in terms of your training and, kind of how you came up?
I don't think so. I mean, I agree with everything that was just said. I mean, you want to get the very best training. You want to get mentors. You want to watch and spend time with and reach out to. I mean, there are a number of people now that are in this space, so that there is a availability of these people, and whether you see them at meetings or reach out to them, always happy to lend 2 cents of advice, and so you don't have to do and make the mistakes that I made. You can learn from other people like myself. And yeah, I think you want to get the broadest exposure so that you can really decide what you like and what you see yourself doing going forward. And you mentioned that academic places are now getting the OBL. That's really important too, to see that in their training. There was no such when I was in my training, but I know Columbia and Dave Sperling do a great job at Columbia having an OBL, even in an academic environment, and more academic programs are doing that, which is great, giving their trainees some exposure to it. And then going to meetings like OEIS. I mean, now there's a whole meeting dedicated to the outpatient space. How great is that? And they spend a lot of good time giving you techniques on business stuff and, getting your team, because you're going to need a team if you're going to do this. You're great at taking care of patients and doing IR. That's the most important thing. But as you mentioned earlier, you got to have your team of people. You got to have your, financial person. You got to have your business person. You got to have, a team of people, marketing. You've got to rely on other people to help you make this successful.
I think if I had to go back and do it again, I think the one thing I've realized, and this is for me, this may not apply for everybody, but I think I was a little too concerned during training how to get a procedure done. I think I was a little too concerned about the technical. And, everybody would always say, give it 5 years. It's probably not going to be as important. It'll be fine. And yeah, they were right. And I think I would have probably concerned myself, honestly, more time having gone off service and rotated through clinics. for instance, on my vascular rotation during fellowship, I had 2.5 months of that, which was good. I, scrubbed in and I did a lot of FEVARs with Mark Farber at UNC, which is pretty awesome. But as awesome as it is to, line a bunch of stents off of, dilated aorta, I think I would have probably been better off going to clinic and evaluating that PAD patient so I didn't have to suffer some of the embarrassments I did when I was treating PAD as an attending, not knowing how to manage things like lipids and blood pressure and things like that. I think it's hard. I think in diagnostic radiology training, there's this tendency to just, study really hard and get good at all the niche little things that you need to memorize to pass your boards. And, I think when it comes to diagnostic radiology for the modern IR, I think it's often understanding the imaging of the patients who you treat, which is very important. And I think when it comes to general diagnostic imaging, it's honestly just being good enough to service an emergency room. You probably don't need to know all the nuances of glioblastoma imaging, though there's nothing wrong with that. But I remember all these, details I'd concern myself with, and time I'd spend learning all this stuff, which is important. But I think that's time in retrospect, I probably wish I would have had a little bit more clinical exposure. It's hard to balance. A lot of programs are changing. It's very political. A lot of diagnostic folks would probably hear what I say and not be a fan of that. But I think you kind of have to advocate for yourselves in IR. So those are my words of wisdom regarding that. Let's see.
Very good point.
Yeah, thanks. I think there was some discussion about OBLs and ASCs and certificates of need. Looks like Ali addressed that, which is excellent. I think maybe we'll just do some final words of advice here for everybody. If you guys just want to final wisdom that you'd impart on people listening here. Ali, you want to go ahead?
Oh man, I don't know. I don't feel very wise. I feel like I'm still just kind of like stumbling through this. And part of it is because I'm at the beginning of this journey still. But it's been like such a great lifestyle change for me to really feel like I have a lot of control over my own schedule and then over the patients I treat and like know that I'm providing the best care. And I think it's an awesome opportunity for women, especially because we're getting more women in IR, right? Like right now we're not 9% or so, but it's going to be way more in the next 5 or 10 years. And just like as it is, we have different lives than male IRs. We have different things we care about. We have a lot of responsibilities outside of the office. And this lifestyle and this career path that I've chosen has really made it so I can fulfill my ikigai. But then I also I feel like I'm using my degree and my skills to the full potential. It's super fantastic. I would love it if anybody wants to come shadow and wants to fly up to Seattle and see. Just would love to share the experience with anybody. Also available for mentorship too. So yeah, highly recommend it. 10 out of 10 would recommend.
Well said.
What about you, John? What final words of wisdom would you have?
Well, I should have all sorts of wisdom, but since I'm toward the end of I'm on the back nine. Just to enjoy it. I mean, we work so hard to get to this place. Enjoy it. I mean, figure out what motivates you. Say part of ikigai is knowing. It's this self-awareness. You have to kind of understand, who you are, why you're here. That you got to figure out your why. My why was to care for fibroid patients. Everybody has their own why, and you got to figure that out and be the best. When you're like Ali said it so well about like she has control now. It's so liberating. It feels great. Same with me. I mean, it releases you and lets you be the best person because your patients deserve that. Your patients deserve the very best IR, the very best you. When you don't have control and you're frustrated and you're burned out and you're worn out, your patients are not getting the best you. They deserve your best. And so you enjoy it. And like, so I would say don't worry about the money. Really not. I mean, and again, it's easy for me to say I'm on the back nine. Oh, you know, I'm telling you, don't worry about it. And who better to bet on? Yes, it is. There is risk. There's going to be risk in anything, but who better to place a bet on than yourself? I mean, really. I mean, you know, I figured if I'm going down, you know, everybody thought I was crazy. My partners in my radiology practice thought I was insane. My wife, we had 3 young kids in private school. She thought I was nuts. It's like, if we're going to go down, I'm going to go down like the way I'm going to get control back in my life. I know there's certain ways I feel I got to take care of patients in clinic, got to have a clinic. I got to do these certain things. And if I can't do it in this model, I'm just going to do it myself. And that turned out to be a very wise decision in retrospect. And it saved everything. It saved my life.
I think you guys stated things that I definitely believe to my core. I think, you know, finding out your why is essential, and sometimes that takes time, actually. I think it took me a little while to figure it out. This is year 7 of doing it for me. And I think what I'll kind of end with is that you don't know how things will go, and you kind of just have to roll with the punches and embrace things. You know, I had no idea that life would take me to this point where, you know, I have an office interventional suite, you know, following, you know, somebody like John Lipman, and, you know, in terms of what I want to do and how I structure my practice. If you asked me 7, 8 years ago, I would have said, I have no idea who that is. And I'm not sure really what I'm doing other than I just want to do cool cases. And I think, you know, what I've come to realize, what's probably more important than all the technical wizardry and interesting things that people talk about what we can do, is it's really about making patients feel good. It really is. I think now that I've done this for a little bit, I don't really derive as much pleasure from doing the cases. I still love it. I love video games. It feels like that, albeit higher stakes. But what really gets me excited truly is actually seeing patients before and after. And I think the more people on this call going forward, if that truly resonates with them, where they can use their knowledge of imaging anatomy and clinical knowledge to make somebody feel better, and that's not always an intervention, actually. And I think everybody here would agree with that. That's what matters. And I think if that's what drives you, you're in the right place. And I think, honestly, if you're going to consider going down this path, it's not even an issue of do I do diagnostic versus do this. If that's even a consideration, just go do diagnostic. You're just going to be really disappointed doing this.
Yeah.
I think this is really, am I going to do something clinically based, ideally surgical, versus this? Because in essence, I think everybody here has a surgical practice pattern. We see patients in the office, we do cases, and we deal with the good, the bad, and the ugly that might come from it. And, you know, thankfully in IR, we got great therapies, and a lot of what we do is a slam dunk. But it's not that way for everyone. Even our best therapies, like fibroids, 10%, 15%, you may not have the best response. How do you deal with those patients? And how you deal with those patients in that moment is what matters, and how you manage them medically, how you make people feel. So I just want to kind of end with that. And I guess if there's no other questions, we'll go ahead and bow out.
Great. Well, really appreciate the opportunity, and say, just like Ali, I'm happy to have people come and visit us in Atlanta, reach out to us, ask us questions. Sometimes people don't want to say something online or in front of other people. Happy to answer stuff offline. We're easy to find.
Awesome.
Thank you all so much for being here. We're sharing your information in the chat, and for all the attendees on social media, you can find all these guys. We've tagged them in posts, so definitely reach out with more questions. Thank you all again for being here.
Thank you.
Thanks so much. Appreciate it.